Okay, welcome everybody to Our Experience, ASCP's podcast. I am one of your hosts, Chad Wers, Chief Executive for ASCP, alongside my tag team partner, Tom Hansel of Hansel Health. And today we have a great episode planned. We're going to talk about why combating medication related problems starts in the home. A major theme for us at ASCP is how do we move to care for individuals in their home setting. We know a lot of people want to age in place. They don't want to move on to assisted living and nursing facilities. So, how do we empower that? How do we handle that? And we have a special guest with us today, the founding president and chief executive of Partners in Care Foundation and HomeMeds, June Simmons. June, nice to meet you. Welcome to the show.
Thank you.
All right. Well, we on this podcast we spend a lot of time talking about you, the person, June. So, give us an idea of your journey and the inspiration behind founding Partners in Care.
Well, thank you. Well, I have a long history as a healthcare administrator, innovator, but my training is actually as a social worker. I have a master's in social work. I spent a long time setting up the social work function and the discharge planning, and then eventually utilization review at Huntington Hospital in Pasadena. And in the course of planning for people to leave the hospital, I developed a big focus about how do they get safe at home and how do they avoid the nursing home whenever possible. I was deeply concerned placing people in nursing homes when we knew that most of them would, the other spouse would soon be bankrupted by that expense. And so I developed a reformist uh, side of my leadership and worked and built systems there to help people master the challenges of dependency and decline, uh, and the ability to live safely at home where they much rather be, and to make that affordable. And so we then I later went to the Visiting Nurse Association of Los Angeles and was their last CEO in a changing environment. They needed to be sold in the face of managed care, but still a focus on the home. And out of their sale, we decided we would create Partners in Care, which is built to develop new models of care outside of healthcare. In healthcare, there are many, many, many innovations, but they're often then caught in budget shortfalls. They don't have baseline, they don't have measurement, they can go by the wayside. So we're dedicated to testing new ways, getting a baseline, measuring the results, and finding what can we do to really align social care and healthcare so that we're dealing with the whole person and optimizing their ability to live where they want and to retain economic safety to the degree feasible. So we began HomeMeds, which is one of our innovations, an early one, at the Visiting Nurse Association. In those days, we had paper charts. We had 5,000 patients at home. The nurses would go out and gather all their meds. It was hard to make much real value out of that look at the uh, meds in the home. And one of the things we did discover is the truth about meds is actually going to the home and looking if there are complex meds. So we had a pharmacist. We were, that home health agency had the first home health in the country to have a full-time pharmacist on staff to facilitate supporting all that, maximizing the value of the care in the home. So Partners in Care is largely around alternative workforce, so that in the shortfall of nurses and physicians, we can bring in social care experts at various levels. Finally, some decades later, payment is changing to recognize there actually are social care specialists who should partner with healthcare specialists, and pharmacists are kind of a bridge because meds are in all settings. And as you know, it's, pardon the expression, cure me or kill me. Uh, Meds are essential. They're curative, but they can also be dangerous, either because they're the wrong meds Thank God for pharmacists because it's so complex now and rapidly changing. Or you can take the right meds wrong through innocent mistakes on the part of the patient. So this is everything we do is not health care, it's social care around health issues in partnership with healthcare providers and payers. So that's our story, and we're sticking to it. That's kind of our core mission, if you will, is to see if we can build a new ecosystem that really aligns social care resources, makes them sustainable. If we say between 50 and 70 or 80% of the drivers of population health outcomes are social and behavioral and environmental in nature, which all the evidence has said for decades. And now we're accepting that. Now, what do we do about it? So that's our sweet spot, is to say, well, if those things matter, which kinds of patients should have social care for which problems, in what setting, for how long, what's the dose, duration, and frequency of the social care that is really sensibly invested to actually get a meaningful change in result in people's lives and in population health outcomes.
I mean, that whole opening statement is amazing. Give us a time frame. When did this all start?
I have to talk that about the fact this is a very slow process in America to make change. So Partners is 26 years old now. So we've been on this path a long time. Um, we focus. So in the beginning, we focused really on end of life care because what we look for is a large population with real suffering and high costs that where a change could be made that would reduce the suffering, reduce the costs, and improve care for everyone. So our first care was around home palliative care, working with Kaiser, who then developed a benefit for because it improved the patient and family experience in the last year of life. It improved the provider experience greatly in the last year of life, and it dropped the cost of care by 30% over the last year of life. So it's feasible. Now, of course, you're moving someone's cheese when you do that if you reallocate dollars that way. Nonetheless, it's worthy. It's a high moral mission, if you will, a meaningful change in care that can meet human needs, fiscal needs to keep the system whole.
Yeah.
Um,
Well,
so
and I applaud that. Like you were so far ahead of your time 26 years ago laying this out. I mean, we talk with our members, our pharmacist members, about what the next 5 years is going to look like from people moving into that older age cohort, those boomers moving above 65 years old, and even a larger number moving beyond 80 years old. And the desire has never been, whether you're on the payer side or on the patient side, hey, I can't wait to get to the nursing home. People don't want to go to the nursing home.
that's right. And
That
they
doesn't,
don't want to have to stay there if they
no,
do.
no.
Right.
And that doesn't mean they're bad. It just means we
No,
want to live at home. Like, of course we
that's
want to
right.
live at home. So,
Home is a passion, and rightly so.
right.
That's right.
And the fact that you've been in that game for 26 years, just there's a wealth of information that you and your team have experienced that is so beneficial as it's finally, I think, government and regulators and agencies are waking up to the fact that we can't just have you live at home, you live in a nursing home. It's got to be support services to help people age where they prefer to
That's right.
age. That's what matters to them.
Yeah, that's where
Well,
majority of them are
it's
going to be.
unique to social work that the social worker isn't giving care and they're trying to help the person navigate the system. And so we're hearing all the things that go wrong and all the forecasting things that likely will. And so I think I had an advantage with my discipline that I ended up in a healthcare setting as this, ancillary and perhaps not even particularly welcomed discipline. But then, pharmacy is underutilized as
I
well.
was gonna say we feel you.
Similar fate,
We
right?
feel the
And
same.
so introducing into a host setting another discipline is complicated, but gaining the insights because we were all in the middle and are in the middle of people's lives, listening to them about because you can't get them to accept services unless you hear what's in the way. They have to really agree to have change, even with their meds.
Yeah.
They actually have to change and take them differently. So I had an advantage, I think, that I think is still not very recognized in the world, that social care people really can bring new information and new
Yeah.
results.
No, certainly. And I love the holistic viewpoint that you guys take. It's not just about the medicine or just about making sure you go to the doctor's visits. You're looking at their entire environment, and that could change in the same town from neighborhood to neighborhood. Certainly, the support system they have around them. Do they have any other family members or any other caregivers that can help them get through some of this stuff? And so I love the fact that you guys are really looking at the holistic viewpoint. I don't think any discipline does that. So that's an exciting new thought process there. You talked about a little bit about innovation, and as pharmacist, I always go back to, well, what does that mean for pharmacy? What does that mean for medications? But can you talk a little bit about maybe some technology that you use to enhance patient medication safety?
Sure, I'd love to. And then we become pharmacist extenders
That's right.
and protectors. If you remember, there was a time when it was kind of, they were trying a new model where pharmacists were driving to the home and looking at the meds. Because going to the home is really valuable. But as one of the physician chair of our HomeMeds advisory says, windshield time very expensive. You should have people work at the top of their license, and you can have extenders with alternate skills. And the community workers are really more affordable for windshield time and maybe better at going into the home and really seeing what's there, gaining trust, and so on. So we developed home meds originally for the nurses in the home health agency because and we worked with Beers. The Beers criteria chaired that panel, was grant funded uh, to identify, if you can, without the pharmacist having to go and look, and without the pharmacist really having to review every single record in the world, who do you have to look at their meds? Who do you need that expertise of the pharmacist from? And so this is a combination. Even then it was. Now, of course, we have better technology, software. You can go into the home and you can root around. You can see what's actually there, and you can sit at the kitchen table and see how it's actually taken. You can, at the same time, observe if there are other environmental issues. Like we had one lady who kept falling. They sent us to go to the home and see why. She kept getting, injured. That when you sat down at the kitchen table, you realized her chairs had wheels, and that was the problem. So you go, well, it's kind of expensive to have to go to the home and figure that out, but there may be no other way. It's less expensive than 4 ER visits for fractures, so anyway, the software captures um, interview, observing the environment for falls risks and other safety hazards, and then dizziness, confusion, a history of recent falls are important to, because what we're trying to really find are what might be adverse meds responses. So we're trying to see, should the pharmacist look at this? The doctor could look, but we think the pharmacist is the expert. And, it's a lot greater variety in the knowledge base of meds with the doc. So we think, let's protect the pharmacist from looking at everything. So we will put in everything, over the counters, herbals, old prescriptions, new prescriptions. We can see now in the modern world, there are places like actual meds where they can get they can do the whole reconciliation. They can get the whole record of all the meds, but this was invented when it was all paper, and this was bold to put it on. Now we have it on HomeMeds. HomeMeds is our software. that we developed that holds this program so that a non-clinician can enter. And we're just making it really even more practical because this still has required going in, looking at the label, finding that med dose and the details. Uh, we're just being funded to get it on AI so we can use anybody, probably the family even can take a picture of the label and it goes in to the algorithm base. And so then you have a completely accurate, you can then put in, well, how do you really take this? Um, we see people who are supposed to take their meds with food, they're motivated to comply, but they only eat once a day. So they take all their meds at once. Uh, we had one guy who was worried he's losing his focus, so he took all his meds in the morning: sleeping pills, 3 doses of blood pressure, pain relaxer. Then they wonder why he looks like a zombie. So deep prescribing and helping people use meds right. These are critically important. So anyway, this goes into an algorithm and it identifies, you know, um, the information the pharmacist can find is his therapeutic duplication. Are there some dangerous meds? Oh, this person's over 85 and they're still, are they taking a lot of Tylenol PM along with their sleeping pills because they don't know those are sleeping pills? Did they come out of the hospital and they have all the new meds, which are probably the same meds, and all the old meds, and they're different colors and names, so they just take them all. So after hospitalization, which is the time we often focus this on, it can be done at any time, but post acute and post nursing home to home, obviously therapeutic duplication is a gigantic risk. And at least 25% of people have that. At least 50 or 60% of the people we see in a targeted population where we say we should do a home visit, these people are at risk of readmission, getting in trouble. 50 or 60% should be looked at by the pharmacist. The meds go straight to the pharmacist. The pharmacist can review and so the more we get fully integrated records, then the better the pharmacist will have a complete database of the medical problems, the history, and all the meds, the ones that have been tried, the ones that haven't, all the things that are magically being added by the person, their neighbors, taking their dog's meds, all the creative solutions people have for these things.
June,
So that,
you're gonna love
yes.
this. I had a pharmacist. We were doing a brown bag at a retail pharmacy and offer people in the community to bring in their medications. This is
Oh,
20 years
yes.
ago.
Sure.
And we had a lady come in and she had a bag of meds. She goes, "These are my husband's meds, and he's too sick to come in, but I wanted you to kind of look at him and everything." And it was inconvenient for her to come in, but that was a value add that we were doing at the time. She whips her medications out. She had 20 vials. 17 of them were for furosemide,
Wow.
for the same drug, different strengths. That, in and out of hospitals, in and out of here. She had 17 furosemides and like 3 other medications. We're like, well, we could help you quite a bit, but that type of, I don't know how many of those he was taking, but my guess is he was pretty dehydrated.
Yeah, can you imagine? And the therapeutic duplication also means they're paying copays on all those meds.
Yeah.
And they're running to the pharmacy to renew. I don't know how they were renewing all
Well,
those
some
meds.
of them were older that they had from different
Yeah,
visits, and they go in
they're
the
just
yard.
using them up.
He
Why
just
wait?
he just brought them all
Wait.
together. Yeah.
Sure. Wow, that's a great story. Yeah, you just see tremendous variety. We have our favorite story about the guy who was in the hospital. He had diabetes. They decided to put him on insulin. They showed him how to take his meds with injecting the orange. And then he goes home and his sugars aren't getting any better. His scores are standard. They increase the meds, doesn't change. Increase the meds, doesn't change. So you send someone out for the home visit, say, now, how are you taking these meds? He says, just like they showed me, I'm injecting the orange and eating it. He's trying to comply. He's
That's brilliant.
adherent. He's just uninformed. So much can go wrong. What we call these threshold problems, whether it's the ER, the hospital, or the nursing home, go out that doorway, and after the threshold, stuff goes wrong. You're on your own, and those sites aren't fully connected. They're getting better, right? We know hospital to nursing home already the meds aren't there. They're, all sort of things that happen. That's why you guys have to be in there looking at them all the time. But then going home, it's even riskier because now people are on their own doing their best. Oops.
Yeah, I mean, we talk a lot on the nursing home side about the advantages that people in nursing homes have. Again, we recognize this is not a place most people want to end up, and it's not a place. It's an expensive place for care. But you have one pharmacy, you have a consultant looking at your meds, you have somebody passing the med for you, nurses involved.
Yeah, you have a lot of controls.
Those are good things that
They are.
somehow we have to replicate out in the community because we don't have that level of control. So we have to come up with ways to innovate. How do we learn about that? How do we make sure that somebody's not injecting their orange and eating it as opposed to injecting it? And I think, again, I guess I'm very positive. I always think it's the golden age of pharmacists, but right now is when we need exactly the kinds of services that you have refined over 26 years and that pharmacists are tooled to do, because the population of people that are in these margins that you talk about, that we tell stories about, are the ones that this is what's happening. These are funny stories, but this is a reality. Like we used to
It's
talk,
serious.
we
Yeah,
used to
because
come to
that
the
guy's still
counter.
going to have an amputation, blindness, and neuropathy
Right,
because he can't control his blood sugar.
right. We used to
So
tell
it's serious.
like corner drugstore stories. Oh, the person came to the counter and we asked them how they were taking their meds, and they would tell us a funny story, and we'd be like, "Oh my gosh, it's ridiculous! You don't take it that way, and you fix it." That's not happening at the counter anymore.
Right.
People are
That's
getting their meds other
that's
ways. Sometimes it's mail order. Sometimes caregivers are bringing the meds in.
sometimes
But they're
all
still
three.
doing those things, and we don't have a line of sight to it. So what Partners in Care is doing is providing line of sight and support to these individuals that need it. And
Eyes and ears in the home, we call it.
absolutely,
Exactly right. And
absolutely.
so the technology can be leased. We're a not-for-profit. This is not a big expensive investment, but it's leased, and then we can train the local providers. So the hospital, more and more hospitals, hopefully physicians, certainly health plans are engaging community agencies to draw on the fact that they are alternatively skilled workforce that is able to gain entrance to the home, gain trust of the person, sit down because they're not there to do vitals. You know how a home visit goes really fast, very focused, check all those boxes, do all those things. This is someone who can sit at the kitchen table and take some time and actually hear from the person and gain insight into what's really happening there. We find a lot of safety risks as well. So you have to target who you do this for. Can't do this for everybody, but you can develop criteria. Some hospitals, for example, use the LACE criteria. And there's a certain zone in LACE where we think it's more useful to really invest in follow up. And so we're leasing this software right now to a lot of community agencies because anyone who does a home visit, we think they actually could benefit from this software because meds, out of the post hospital, that's the number one driver of readmission. Is getting the meds wrong. It's um, it's crucial. And how expensive is it? Readmissions are. That's how we got into care transitions was everyone noticed, oh my goodness, at least 20% of the people, we invest all this money in putting them in the hospital and fixing them up, and then they fail. That should be less. So, we're working with systems now where we cut that in half. Some stuff will still go wrong, but it's so important. So you can pay for the not very expensive cost of home meds and the home visits associated and the cost of the pharmacist review. Those are the factors that go into home med. We don't make a move without the pharmacist. Um, and you can have really valuable results, preventing falls, preventing readmissions, preventing the decline, because when you discover the things that should be deprescribed, as you noted, 17 of the 20, he should have had 4 meds. Much easier also to get through your day with 4 meds,
Certainly.
right? Instead of 20, your chances of getting it right are improved.
Well,
We
that,
you
that
said you said two magic words, June, we I try to highlight, we try to emphasize all the time is our healthcare system has eliminated time and relationship
Yeah,
from the system. And what you just described is how do we get time with the patient in their home? And how
right.
do we develop a relationship of trust? Because ultimately, we know those two things solve so many problems. And
Truly.
it's unfortunate that our system has fed itself on speed and more scripts per hour and more patients per hour. And it's become this almost
A
industrialized
grind.
Yep.
Yeah,
process.
no, it
Volume
is.
based.
It's an assembly line.
And
Yeah.
the answers are no, no, no. We just need some time and develop a relationship, and we can make some major headway into changing somebody's life and improving their quality. Um, what advantages, if you've talked about the pharmacist and how integrated they are in your system. What are some of the insights and advantages that you want to share about the HomeMeds program to our pharmacist audience?
Well, we work with a couple of pharmacy schools, and we work with a group that has pharmacists all across the country, because these are problems across the nation, and so one of the issues is how do you get a pharmacist that maybe is trained to the high risk kinds of populations somebody's looking at, and they have to be licensed in that state. So we're in 20 states just leasing the software. We don't provide the service. We train the agency that's doing the home visits. They have to have a pharmacist. So who's that going to be? So I think, this is an area of importance. And a new area seems to be that nursing home beds are on the decline. Their use is shifting strongly to skilled rehab kinds of functions, shorter stays, and probably those facilities be happy to not have the Medicaid patient live there forever and just really be a rehab alternative. Uh, so, uh, maybe the pharmacists will become skilled voices for thinking how to help encourage uh, continuity from the nursing home to the home. And the pharmacist's role can move over. They're in the nursing home, carefully monitoring and managing those meds. The patients go home faster and faster. Um, if there's a relationship with the nursing home, which is a new innovation we're pursuing, figuring out who's the payer, and the pharmacist role can continue, it seems like it would really be sensible because they know the patient, they know the record, and they know the community. And these are briefer interventions. Care transitions can just be a 30-day intervention with one home visit and some phone calls. That one home visit sees what other meds are there and what else is patient doing about food that should go with the meds. What are they having? You probably would have a good example of what they should not be having. Grapefruit with their statin. You make the home visit and you go, oh, they've got 3 bottles of grapefruit juice. um, so finding things that will ruin the effect of the meds, or complicate the effect of the meds. I think those kinds of partnerships, pharmacists are crucial. The home visit, it's like the home health visit was with a paper record. You don't get the full value of investing the person going there if you can't take what you find and get it in the right brain trust. And the doctor isn't going to respond to the community health worker. They may start to, because they're now the new Medicare payment rules will allow physicians to have contracts for social care workers to follow their patients in the community. We'll see how broad the adoption is, but that could be powerful. We still need the pharmacist in that equation. So the HomeMeds being part of that arrangement embeds the pharmacist in that arrangement. So I think each of again, I think I said at the beginning, with care transitions now, people they get their care and they leave the setting, they cross the threshold. A lot of stuff falls apart. ER, hospital, nursing home, they're all places where our social care and pharmacist practices can uh, synergize uh, to really optimize population health outcomes in partnership with payers, in partnership with providers, and maybe in partnership with families. We haven't done this as a consumer based app, but I suppose it could be.
Yeah, so that's what I was going to ask you is how do you get the word out? How have you guys gotten to 20 states and how do you continue to educate? Are you going now to the nursing homes, hospitals, those type of things, or how are you guys scaling?
Yeah, we need help in scaling. So we're just looking at that and seeing what partnerships we can build and can we do that. Again, because we're community based, our voice may or may not be the best, most not might be the best, might not be the most credible voice. But we work at the national level. We go to aging conferences for community care that serve older populations because that we can find that in a lot of what happens at home is around aging. Aging and disability are clearly the issues we're targeting. And so then we try through that to market to their member agencies, the area agencies on aging all across America, the senior centers, um, the disability services networks, and have them contract for home meds. But they are not very well funded. Most of the money's in healthcare. So healthcare really should be the sponsor of the arrangement. So we're working with hospitals here, and we're just looking. I'm in California, so we have new Medicaid, and we think that we are about to try to deploy the new Medicaid opportunities to bring a social care person in to meet the person in the hospital so you can engage them because getting them to even let you come to their home not too easy. Building that trust, and then you can follow under the new Medicaid in California. You can follow with care coordination actually past the 30 days. So, and you can address younger populations as well. But you can also serve the duals. So, if there's a Medicare patient in the hospital and they're a dual, they can qualify for the new Medi-Cal care post-acute care coordination. So we're just trying to build that out because then, as you know, under Medicare's many defining rules about what makes something really billable. But if this isn't billable, it's not going to scale. So we're just about to test that. We have one major hospital system that where we've been doing it, and the hospital's been paying to reduce readmissions for um, fee for service because they get penalized. But in the pressures they're under, they're facing layoffs, they're facing the cost of travelers, all kinds of pressures on hospitals. So we're about to experiment with how can we draw down the Medicaid and the Medicare, and how can the hospital get and us get the health payers, the whether they're managed care groups, ACOs are starting to be interested in this now. um, the health plans, the Medicaid and the DSNPs, the Medicare Advantage, they could all jump into this and we could figure out a better way to get um, a return on investment in terms of quality scores, patient experience, actual clinical outcomes, readmissions, frequent ER use, shortened nursing home stays. So ambitious, but that's our actually been our basic ambition for a couple
Yeah.
decades.
Well,
So we think
it
there
makes
might be
total
new
sense.
levers for change now with the new
Yeah.
payment.
That makes
So
total sense. I mean, everybody's now in some way or another held accountable for rehospitalizations.
yeah.
Nursing homes just as much now as hospitals, that they go through that nursing home. And so everybody's goal is to avoid rehospitalizations. And this
And
is
to
just,
identify social factors that drive
yeah,
health care. They're
that's right.
supposed to. Now, are they able to do that? So a lot of we do training also. So we're trying to now see if we can train the hospitals and the medical groups to know when they see one, which social factors should we address
Yeah.
that will really make a difference. We're talking in San Francisco with the food as medicine community providers and one of the health plans, and they're interested in maybe we could, because we have what we do, it's too hard for every little agency to be contracted to be paid. We're talking about paying them to make this sustainable and to have everybody countries. We created a concept called the Community Care Hub. So there's an anchor agency in the community that builds itself up to be able to contract with health plans and hospitals and large medical groups. And it then can draw a credential, train, provide the IT support, do the compliance and quality, the billing and coding. Let those guys do what they do well, which is the social care, and let the business arrangement come through the community care hub. So we invented the community care hub concept about a decade ago, and we're trying to deploy that as well to scale this. If I can go to all the Medicaid plans in Los Angeles County, which I have, and arrange a network of agencies that are what we call a regional geographic social care delivery system, whatever region the payer needs, uh, and get consistency and quality out of those alternative experts. We have a shot at something that might work. But as you can hear, this is what we call a worthy goal that requires disruptive change.
Absolutely. I just did a I was on a virtual call with an organization that called themselves the Arlington Neighborhood Village. And
Oh, yes.
it was basically, and they said there's 40 of these around the country.
Yeah, it's all
It's
volunteer neighbors.
volunteer. They're neighbors.
They're
It's like
time banking,
yeah.
right?
And
Yeah.
they, we had, I don't know, 45 or 50 people on the call. I was one of the, they do a weekly presentation, and I was the presentation this week. So I mean, everybody is engaged in this, particularly the individuals that are seeking solutions. Like, these are all people that have joined a club, for lack of a better term, because they want to age in place and they want to
That's
age
right.
healthy and they want to learn things and they want to be involved in social activities and not left behind and all the things. And
That's right. Right.
what you're doing on from your perspective, what they're doing from their perspective, and ultimately, as you've mentioned, what payers need to be thinking about, for even if it's just fiscal responsibility, if that's all you're doing it for, we all are on the same page. We've got to
Yeah.
figure out how to do this stuff.
I don't care why they do. They wouldn't do it for their bottom line,
Yeah,
improves their quarterly returns to pay for fewer readmissions.
yeah,
Hmm.
Great. Let's just
yeah.
get better care to people and find a way for everyone to win.
Right.
I'm,
Everybody needs to win.
I'm not trying to hurt anybody. I think
Yeah,
we can do it better together.
Yeah.
absolutely. Well, June, this has been awesome. I really appreciate you being on the podcast. You are definitely a pillar of our industry, and your insight and your team's experience are just, paramount to us moving forward with a population that's going to need our help. I mean, bottom line, and what you've been doing for now coming up on 3 decades is what we really have to have start happening now.
Well,
Uh,
I love that you gave us this opportunity because pharmacists can be such important leaders, and you're spread all across the country.
Hmm.
And if anybody of your members want to think about community partnerships
yeah,
or learn more, we would be happy to share that. And then the Partnership to Align Social Care is a national group I co-chair. They can find that website, and they could step up. We can have a pharmacy voice. We're trying to build the ecosystem to align social care and health care, and pharmacy's right in the heart of that. So we love to work with you.
I promise you that if we had a phone, it would be ringing, and you're probably going to get a lot of attention from this podcast from our pharmacists. We have a lot of entrepreneurial pharmacists that are
Hmm.
looking specifically for things like this because they
If we get
recognize,
that, we'll work with you. Maybe we can create a dialogue
yeah,
webinar
sure,
where we could just talk it through with people who have interest. We'd be glad to do that.
absolutely, we will definitely do that. Tom, any last words?
Yeah, I'm sold. June, I vote yes. No, this is fantastic, and it's definitely eye opening. And I just love the approach. It's outside what we would traditionally call as healthcare, but it's essential to the success of that. And I believe in it. I believe that this is going to be it's already greatly needed, and I think that need's going to double or triple over the next
This
few
is true.
years.
This is
So
true.
I vote yes on requiring it any way we can. I think it's
Now
a
you're
win for
making my
everybody.
day.
Yeah,
Thank you.
absolutely. I mean, when you look at it, we all know this is a problem to solve. We all know that as people get older and living at home, desire to live at home, their medications are getting more and more complex. They need this. And we know that. And we're looking around for solutions. And you have a lot of insight, experience, and some solutions that we need to amplify.
That
And
we could do together because we
yeah,
can't do it without you.
yeah, absolutely. Well, thanks so much, June.
Thank you.
Appreciate you being on. We'll look forward to seeing you again. And everybody out there, I hope you enjoyed our experience, and we'll see you next time on the podcast.